Hello everyone and welcome back for part 2 of the introduction to pre-hospital pre-oxygenation. My name is Austin Kaiser. I'm the clinical educator as well as a flight paramedic for PHI in California. Let's get going on part 2 of this presentation, which is the Airway map. Now every company nowadays does seem to have more and more a map or kind of an instruction sheet for being able to work through the airway, and we are going to introduce you to the safer airway map that PHI uses. So this right here is broken up into two parts. This is the Crew 1 checklist. There's also a Crew 2 checklist for your partner. You can see that all of the Crew 1 items are going to be in green and all of the Crew 2 items are going to be in red. For this presentation, we are only going to be focusing on Crew 1. And then when you get into your pre-academy time with your state clinical educator, they're going to walk you through this map a lot more and introduce you more to the Crew 2 section. But the Crew 1 is really what we want to focus on right now. So let's break down this airway map and take a look at all the facets of it here. So the first box that we come across is the setup box. And what that means is that when we walk into the back of the ambulance, we walk into an emergency department and we are going to start to do an intubation procedure, we're not going to continue using the equipment that that facility uses because they typically don't have all the things that we need as far as the type of bag valve mask or in-tidal CO2 or our heat moisture exchanger, our PEEP valve, or whatever you have it. They typically are not going to have what we need. So what we need to have is pictured here. We need our PHI bag valve mask that is equipped with a manometer. We need a PEEP valve. We need our in-tidal CO2 monitor. We need our heat moisture exchanger and our mask. You can see right here the manometer that comes with all PHI bag valve masks, and the manometer is very simple. It's color coded. You can see that if you keep it under 20 centimeters of water pressure, you're in the green, and what that means is that if you are doing BLS ventilation, you have to keep that manometer under 20 if at all possible, because you know that you will not be breathing into the stomach, right? Over 20 centimeters of water pressure, we open up that esophageal sphincter and we start bagging the belly. So we want to keep it in the green. If you do make it into the yellow zone, anywhere between 20 to 40 centimeters of water pressure, you're going to be ventilating the stomach as well. Anything over 40 centimeters of water pressure, you are going to it's going to be a little injurious for the lungs or greatly injurious for the lungs, and so we want to keep it out of that red zone as best we can. So what we need a nasal cannula, and this is not an in-tidal CO2 nasal cannula. This is a regular nasal cannula. We need a bag valve mask. We need our PEEP valve, which you can see pictured on the bottom left there. We need a bag valve mask that has our manometer on it. We need an in-tidal CO2 detector, which most of you know what an inline in-tidal CO2 detector looks like. And then in the middle on the right there, that little filter looking thing is our airway humidifier. It's a heat moisture exchanger. It essentially tries to keep some of the humidified air or the humidification inside of the lungs, because we are going to be delivering a lot of cool, dry air, and we don't want to perpetuate any type of infection or ventilator-acquired pneumonia or anything like that. And so keeping moisture in the lungs is going to make the lungs a lot happier. All right, so we have our setup. We have our bag valve mask, our PEEP valve, our nasal cannula, and now we are going to initiate that mask control. So we need to get immediate mask control using 2 thumbs down masking, getting a good jaw thrust in there, and making sure that we have our nasal cannula at 15 liters per minute. We have our bag valve mask at 15 liters per minute, and we're dialing our PEEP up to 10 to 15 as well. If you want to make it easy on yourself, you can turn all 3 of those devices to 15 to make it a nice 15, 15, 15. And so we have our nasal cannula at 15, our bag valve mask at 15, and our PEEP valve dialed to 15 centimeters of water pressure. So we have this perfect setup. We're doing 30 liters per minute of flow. We're getting some really good passive oxygenation because we've got that PEEP in there, so we're putting pressure behind our flow, and for some reason we're still not saturating well. The most likely reason is that we have improper positioning. We've all learned to put our patients in the sniffing position, the quote unquote sniffing position, but I know that I myself was never actually taught really the correct way to put somebody in the sniffing position. I was always under the impression that doing a head tilt chin lift put somebody into the sniffing position, but that's simply not true. We need to be physically raising that head up, putting that ear to the sternal notch, which we'll look at a video here in just a second that explains that a lot more. So you can see that the tracheal axis and that oral axis, that blue and that red line, they really need to be a straight line. They need to be 0 degrees in order for you to have the perfect axis. So they didn't really get it with just putting a pillow. They put some blocks under there, and it did make that angle a little bit wider, probably a little easier to intubate that person. But as you can see in this picture right here, those are in a complete straight line. They really raise that head up. If you look at that gentleman's ear, you can see that his ear is raised all the way up to his sternum. And so that's what we refer to as raising the ear up to the sternal notch. It's a very important aspect of preoxygenation and super important for intubation. It's probably one of my biggest things that I suggest that people never forget is that they really focus on getting that ear to the sternal notch or the sternal line, because if you don't, you're going to diminish your chances of first pass success pretty greatly. So PROTECT is an acronym that we have here at PHI that helps you to really get good mask control and really make sure that your patient is able to oxygenate well. So the first thing that we're looking at in the P is we are positioning our ear to the sternal notch, making sure that we are really getting that head up on pillows or towels or a bag or whatever we have. The R is that we are physically raising the mandible up toward the ceiling. We want to make sure that we have our ring finger and our middle finger behind the angle of that mandible, and we are physically raising it up toward the sky. We're putting in an airway adjunct, so we have our OPA or our NPA. The first T is that we're doing thumbs down masking. Make sure that thumbs down masking, we are doing a 2-person bag valve mask technique. We are not doing a 1-person technique. We're using a C and E grip. The E is that we are assuring that we have end-tidal CO2 with every breath. So we're looking at the cardiac monitor and we're making sure that we have end-tidal CO2 waveforms. If we don't, it means that we probably are not positioned very properly or that the patient is apneic. The C is we're checking our O2 and our PEEP, so we need to have 2 oxygen sources, so that way we can have a nasal cannula at 15, our bag valve mask at 15, and then our PEEP valve set to 15 centimeters of water pressure. And then finally the T is that we want to assure that we don't have a tension pneumo or any big gastric distension, otherwise we're going to need to decompress those. Additionally, we need to make sure that our partner very quickly gets the suction out, puts it on, and has it ready to go and sitting underneath the patient's right shoulder with a decanto suction. So after we have got our setup, we've got mask control, we've gone through our PROTECT, so we are positioning the ear to the sternal notch, we're raising the mandible, we've put an OPA inside the patient's mouth and they accepted it no problem. We are assuring that we're doing a 2-person bag technique using 2 thumbs down. We have end-tidal CO2 waveform on the cardiac monitor with every single breath. We've got our O2 and PEEP dialed in at 15, 15, 15. And we also don't have any issues with any tension pneumo or distension. So we've gone through our PROTECT. The next thing that we need to decide is we need to decide, do we need to bag this patient, or essentially the CPAP that we're currently giving them, is that enough? And there's a pretty easy way to answer that question. So you have to understand that CPAP, what we're giving this patient, essentially we're giving them 30 liters per minute of flow with 15 of PEEP, so we're giving them a pretty good amount of CPAP. That's going to fix any oxygenation issue that they have. However, When we're optimizing ventilation, remember that ventilation means that we're talking about end-tidal CO2. So in order to determine whether we're going to bag this patient or not, we just simply need to look and see on our end-tidal CO2 waveform, is the patient spontaneously breathing? Is it adequate, or is the end-tidal CO2 60? And do we need to periodically squeeze the bag? We don't need to be bagging this patient typically, 16 breaths per minute. We just need to be bagging them periodically to make sure that they are that they are adequately ventilating. So real quick, if you do decide that you need to bag this patient for any reason because their end-tidal CO2 is high or they're not having good spontaneous breaths, a quick word about volume. In positive pressure ventilation, the maximum amount of volume that we want to give to our patients is about 8 milliliters per kilogram of their ideal body weight. So let's take like a 5'7" female. She has an ideal body weight of, actually that's a typo, she has an ideal body weight of about 65 kilos, which means that the tidal volume that she needs is about 500 milliliters, give or take. 480 would also be perfect. So how many milliliters are we capable of giving her with an adult BVM, right? So we know that we want to give her a maximum of about 500 milliliters. But how many mLs is in an adult bag valve mask? And I think that many people would probably be surprised to find out that there are 1,600 milliliters in an adult BVM, 1,600, which means that she only needs about a third of the bag in order to be adequately ventilated. Or adequately volumized, really. So if we think about it, in the wrong hands, a bag valve mask is a pretty effective murder weapon, and we need to make sure that we are not letting the person who's squeezing the bag, we're not letting them use two hands, we're not letting them fully squeeze the bag, because when we are doing two thumbs down masking and we're raising the mandible and we've got a really good efficient seal on that mask that's not having a bunch of leak, it can be incredibly dangerous to give them those big volumes. So we need to make sure that we're watching to make sure that the firefighter or the EMT or the paramedic is not over volumizing our patients. All right, so the next thing after optimizing ventilation is that we're going to look for a difficult airway, right? One of the biggest failures for airways is that we get in there without having a plan beforehand, right? You just kind of treat it like it's any other intubation, and all intubations are unique, and every patient's face is a little different, and every patient's airway anatomy is a little more anterior or posterior than the last one that you intubated. And so it's really important to have a physical plan in place for this airway. There are many different airway assessment tools, and while SAFER does suggest doing a lemon assessment, which you can see down on the little graph right there that we have, look for a difficult airway, evaluate something called the 3-3-2, which is pictured in figures A, B, and C. You want to be able to fit 3 fingers, their own fingers, not your fingers, 3 of their own fingers in their mouth, 3 fingers between the chin and the front of the thyroid cartilage, and then 2 fingers above the thyroid cartilage until the hyoid bone. And that will mean that that patient is going to be pretty easy to intubate, that they are not super high and not super anterior on their trachea. And then the M is evaluating a Mallampati, which you can only do on a fully conscious patient. O is look for obstructions, N is check neck mobility. And so lemon assessment is what is suggested on the SAFER form. In our clinical care guidelines, it does just say any airway assessment that we can really do, but the important part of it is performing an airway assessment. So is there trauma in the airway? Is this patient morbidly obese and is going to naturally be an anterior airway? Are there obstructions in the airway like dentures or gum or chew or whatever you have? There are many ways to assess an airway, but we want to make sure that we identify any issues that we are going to potentially have, so that way we can mitigate those with using either a different airway adjunct like a rigid stylet or a bougie or what have you. All right, so during this time, we've been getting good mass control for several minutes, so you're probably going to have already reached 100% saturations a minute or two ago, but maybe because of really poor hemodynamics or incredibly bad alveolar shunt for some reason, you may not reach 100% saturations, but once we have reached either 100% or we have reached the highest attainable SpO2, meaning that they plateaued at 95% and then you readjusted the airway, you made sure you were getting a really good seal, you maybe adjusted your PEEP from 10 up to 15, and now you've gone up to about 98% and it plateaued again and you weren't able to get it above 98%. That's totally fine, right? All we want to do is we want to get the highest attainable SpO2. So now what do? Remember from the part one that it takes 3 minutes after reaching maximum saturation to have full alveolar denitrogenation. So we need to physically have somebody set a 3-minute timer in order to identify our denitrogenation time, right? So we need 3 minutes of mindful denitrogenation in order to do this step properly. So we are oxygenating. And 3 minutes is a super long time, right? So you can do a lot in 3 minutes. So what are we going to do in the meantime? Well, we are going to talk about the plan. And on the Airway map, this is actually a Crew 2 responsibility to talk about the plan. And I completely agree with that. But I think that this is such an important step in the process that it really does need to be mentioned in this video. I think that there is nothing worse in a team dynamic like in an emergency department or in an ambulance when one person is trying to have this sole kind of responsibility and decision-making power, and if the procedure that they're doing fails and they didn't communicate beforehand, nobody really knows what they're supposed to do if the airway fails, right? So at PHI, before we ever do an intubation procedure, every single time we're going to talk about our plan. And this is our plan at PHI. We are going to attempt our first intubation with the primary intubator, the Crew 1 person, and 90% of the time that person's going to be successful. However, if they are not successful, we are going to re-oxygenate and re-ventilate them, getting another oxygen saturation of 100%. We are going to do another 3 minutes of mindful denitrogenation, and then we will do a second intubation attempt. Making sure that if you do have to do a second intubation attempt, you cannot use the same materials that you did during the first intubation attempt. You have to change something about what you did, right? So if you used a bougie, then now we have to go in with a rigid stylet. If you couldn't pass the tube because the vocal cords were really narrow, then you are going to downgrade from an 8.0 to a 7.5. And so we need to change something about our second attempt. If the second attempt fails, then we are immediately going to insert an iGel or some sort of supraglottic airway device, which I believe almost every program at PHI is using the iGel. If the iGel is successful at maintaining oxygen saturation above 93%, then we are going to continue to use the iGel. We can place them on the ventilator with the iGel, and then we're going to continue our transport. However, if the BLS airway fails, if the iGel fails to properly oxygenate them due to whatever issue, we are immediately going to enter into a surgical crike and cut the neck. So obviously that was a pretty long drawn out thing, and not everybody in the back of that ambulance needs to know every single thing that you're going to say, but you can very quickly and very succinctly communicate your plan, which never changes, to everybody in the back of the rig. So you can say, hey, my partner here is going to try to intubate. If for any reason we're not able to intubate, we're going to repeat this preoxygenation plan, and we're going to denitrogenate for another 3 minutes, and then we'll do a second attempt. If that is unsuccessful, we're going to go ahead and do a backup airway. We're going to use an iGel. If an iGel is unsuccessful at keeping their oxygen saturation above 93%, then we're going to go ahead and cut the neck and do a surgical crike. Are there any questions from anybody in the room? And that's really all that you have to say. So you communicate the plan. Now every single person in that ambulance knows exactly what they're going to do if the intubation fails, right? So really important to communicate your plan. And now the intubation happens. So the biggest thing with the intubation is that we need to lead with suction. So we are going to put our suction in the airway first, and you'll see that on a video that we're going to put on here, or that is in part 4. We're going to lead with suction. The number one reason for first pass failure is that you go in and you can't see anything because of blood, vomit, or secretions in the airway. So lead with suction. The suction goes in your right hand, and you plunge the suction down into the oral pharynx, and then you'll follow the blade in after the suction is already in. And the biggest thing with intubating is that I think that we were given a lot of injustice by saying that we do laryngoscopy, right? Because coming from the paramedic side and having intubated many people, that never happens. I never insert the blade, lift, and immediately see vocal cords, right? That's just not something that happens in real life. And so really what you should be looking for is the uvula, right? So we're not immediately looking at that end goal. We're not immediately looking for those pearly white gates of the vocal cords. The first thing I'm going to look for is the uvula, right? The biggest factor in success for intubating people is not necessarily knowing how to get to the vocal cords. It's knowing where you are currently in the airway and being able to adjust down from there. So if I don't see my uvula and I'm just trying to go down deep into the airway and I lift that tongue up and out of the way and all I see is pink in the back of their throat, I have no idea where I am. But if I go in gradually and I first see the uvula and I say, hey, I have uvula, I know that if I travel down the tongue, I should start to see the tip of the epiglottis. And then I say, hey, I've got epiglottis. I'm going to slip down into the vallecula, or I'm just going to grab the epiglottis and get it up out of the way. Once I start to lift from there, I know I should start to see the arytenoids between the vocal cords and the esophagus. And from there, I know that anything above those arytenoids is going to be airway, and anything below those is going to be esophagus. So once I push forward toward the toes a little bit more, I should be able to displace that epiglottis enough in order to see those vocal cords. And now I can very easily pass the tube, make sure that I blow up my balloon, my cuff. And then I'm not going to pull out, right? I'm going to maintain that visual because there's no rush at that point. You've intubated them successfully. You have your cuff inflated. There's no reason to pull out of that airway. It's not going to inhibit your ability to give breaths. So you need to stay there and look at your view and watch that cord sitting between the vocal cords until you've given your first breath, until you've checked lung sounds, and until you have a positive waveform capnography, right? We don't use the colorimetric devices. We use waveform capnography because that's the gold standard. So make sure that you keep your view during all of this stuff until you have a definitive airway. At that point, you can pull your stuff out. You can secure the tube with whatever commercial securement device you have. Make sure you state the depth of your tube, and then you check the cuff inflation as well. All right, guys, so thanks so much for hanging out during part 2. Again, my name's Austin, and if you'd like to leave any comments or questions regarding this video, please feel free to reach out to me at akaiser@phiairmedical.com. And we will see you guys again for part 3 of this video series.